Good afternoon. My name is Kelvin Lee. I'm the director of the Huda Salman Comprehensive Cancer Center, and it is my great pleasure this afternoon to welcome you to Simon Says Immunotherapy 101. I have two illustrious speakers and guests today. Dr. Huda Salman, who is the director of the Brown Center for Immunotherapy here at IU Simon Comprehensive Cancer Center. We were very fortunate to snag Dr. Salman from SUNY Stony Brook to lead our efforts here in immunotherapy. And my second guest today is Dr. Matt Opyrchal, who is our Vera Bradley Scholar in translational cancer research, and is also the director of our early phase clinical trial program. We have had the opportunity to steal Matt from Washington University, and I've known Matt for quite a while when he was at Roswell Park Comprehensive Cancer Center. So with that, my job, as you can tell from my bow tie and my suspenders, is to say, speakers, start your presentations. So I will start with Dr. Salman and have her do an introduction in immunotherapy and talk about her favorite immunotherapy, CAR T-cell, and then move on to Dr. Opyrchal to talk about other immunomodulatory approaches. Dr. Salman.
Thank you so much, Dr. Lee, and good afternoon, everybody. Thank you for attending this talk and seminar, Simon Say. I am going to share my screen. And do you guys see my screen? Okay, so I would like to start by some statistics about cancer diagnosis and cancer deaths in the United States. So as you can see from this picture and slide, here we have the estimated new cancer cases in the United States, and here are the estimated deaths in 10 top of the cancers that we diagnose here. So, for example, we diagnose about 270,000 of prostate cancer. Of those, every year we lose about 34,000. I don't mean of those, but we diagnose this number and we lose this number. They might be diagnosed the year before or the year before. And in the male department, and for our lady patients, we diagnose about 290,000 of breast cancer, and we lose about 43,000 patients with breast cancer every year in the United States. And the cancer death depends on many factors, such as how aggressive, age of the patient, and tolerance to chemotherapy, but also it depends on how much we know about how we treat these cancers. For example, we have a leukemia here, which is one of the very aggressive tumors. We diagnose 35,000 patients, and then we lose about half of them, or half of that number every year. And this slide will show you how cancer death, which is the green, compares to other etiologies of death in the population. The blue is all cases, and then the orange is heart disease, and cancer is green. So as we can see, heart disease and cancer, they are going hand in hand. And now we have COVID-19, as you can see. Before we did have zero mortality because of that, or so, and now since 2019 it's catching up with causes of cancer death of every year. And also, like I said, the death rate depends on, one of the things that it depends on is age at diagnosis, because as we get older, cancers get more aggressive, as well as patients do not tolerate a lot of treatment that we can provide for younger patients. And so there is a big room for improvement in treating cancers in general. So although I hate to, or I avoid to tell my patients that their journey during their cancer treatment is a war, and or use descriptions that are not used in other diseases, such as the body is riddled with cancer or this and that, and I prefer to use cancer is invasive and aggressive rather than cancer is a war. However, we really acknowledge that at the cancer site, it is really a battlefield. So if you look at these lavender color cells, they are cancer cells of the colon in this case, and the immune system is trying to send all sorts of cells, such as the fibroblasts, to sort of contain it, such as the T cells to sort of try to kill these cancer cells, and such as a B cell to try to enhance more T cells and other soldiers that will help the body overcome this aggressive and invasive growth. So down there where the cancer growth is, there is a lot going on. And understanding all of these features will help us, or already is helping us, trying to augment what is in favor of the body rather than in favor of the cancer. And that's a picture that we see collectively, possibly in all of the tumors that we come across and we treat. So, we love the work of Dr. William Coley, who lived between 1862 and 1936, and he is known as the father of immune therapy. And the reason for this is Dr. Coley in 1891 decided to stimulate the immune system to treat cancer. And the only way that was available to him is to inject bacteria into cancer victims. And this bacteria was supposed to stimulate the immune system, and then as a side effect, it will shrink the tumor. And he was successful. In Memorial Hospital in New York, he treated over 1,000 patients with this approach. But despite the success, Dr. Coley's approach was abandoned by many physicians, especially that at that time, there was a lot of chemotherapy and radiation therapy coming up. And then they used to call his methodology the toxins of Dr. Coley. And then that approach faded down, only to be revived very recently by understanding more about the immune system and how it works and how to stimulate it and how to harness it in terms of in favor of treating and curing or even curing cancer. So the immune system at a glance is our natural defense system, and it is composed of many organs in the body, such as the tonsils, which are lymph nodes, the nose, which has a membrane that will prevent toxins as well as bacteria and all of that to come in, the thymus that produced most of the cells that are important for the immune system, and so is the spleen, lymphatic vessels, lymph nodes, and bone marrow, and then the white blood cells that come out of the bone marrow. We're going to zoom in into this and get this picture to just illustrate how this immune system does what it does. So it is composed of multiple cells that we, in the research side, we divided into innate immunity and adaptive immunity. And there is some overlap there because some of the cells function as both ways. But I want to elaborate on two important cells. One is the dendritic cell and the T cell. And the reason I want to do this is we focus mostly on those two cells when we speak of immune therapy and immune approaches. So we're going to zoom in again into these two cells, because for the T cell, which is the biggest part of the immune system to function and to kill cancer cells, the cancer antigens or cancer protein has to be presented by this other cell that I pointed out, which is the dendritic cell. And the way that happens is that these cancer cells, either the cancer cell or part of it or a protein that is secreting, will come, and this dendritic cell sort of engulf it into its boats right here. And then these pieces of this cancer will pass through the dendritic cell, and then from somewhere on the surface of the dendritic cell, it will be presented to the killer T cell, where this immune system cell or killer T cell will ultimately lyse or kill the tumor cells. So our understanding of all of this made us, and Dr. Coley in the past, ask the question of how can we make this stronger, this response of the T cells? How can we make it more able of killing these tumor cells? And there are about 4 strategies in general that to design immunotherapy. Some of them are non-specific immune stimulation, such as the methodology that Dr. Coley used by injecting bacteria, and or by utilization of immune check blockade, which Dr. Opyrchal will be talking about, or by what we call an adoptive cell transfer, meaning to do some modification of these cells and bring them back to the patient, and or by doing a vaccination strategies for the tumor, like we vaccinate for bacteria. And the vaccine concept is that, again, we put some of the pieces of the cancer or the bacteria into the body so the immune system will react, and then that will strengthen it. And so we can utilize some of the tumor antigens, a non-viable tumor, and inject it in a human body and then get that stronger immune reaction. And as for the adoptive cell transfer therapy, it could be, again, something very simple, and I mean this is for just stimulating the immune system by injecting some proteins, and then they will stimulate these dendritic cells to become hyperactive and then attack the tumor cells, or by the adoptive cell therapy, which is one of the methodologies is by creating chimeric antigen T cells. And this concept speaks or involves getting a T cell from a patient or a donor, and then introducing a strong piece of DNA into this cell. This piece of DNA carries some messengers for this cell to become stronger, or some messages. And those messages could be a more specific way of catching the tumor antigen by making it a little bit more specific. And also it could be adding a small protein into this DNA material that will really augment this T cell to multiply and become stronger. And the outcome of this is we call a CAR T cell or a chimeric antigen receptor type T cells. So in a big picture, the difference between the cell after we introduce this material through a disabled virus into the DNA machinery of a normal T cell that is non-enhanced, the difference between this normal T cell before and after is that it becomes equipped with all of these new small lupinary proteins that will make it more strong into recognizing tumor antigens. And so this is a normal T cell, and this is a CAR T cell after we introduce all of this genetic material that this T cell will utilize to start producing these stronger proteins to attack the cancer. And the way we do this is we take these cells from the patient or a donor, mostly from a patient nowadays, and then we move it into our facility where we can introduce by introducing this transgene or the piece of DNA into these cells, and then expand them in the laboratory, and then make sure that they pass some release criteria by regulatory bodies such as the FDA. And then we remove what we need to remove from them that the patient does not need. And then we, after we give the patient some doses of chemotherapy to make them more acceptable to that particular patient, then we infuse those modified T cells. And we know that they are now augmented and stronger, and they're going to go and fight the cancer. So let's assume this is a cancer cell, and these are the cells that we introduced with all of these weapons that we have included in their DNA, and then they will attack this. They will find some certain ligands or receptors for their killing activity on the tumor cell, and then they will rupture this tumor cell, these T cells, and then move into their merry way to find another tumor cell and do the same thing again. So conceptually speaking, this is how these CAR T cells will function. And the world has gotten very busy producing more and more of these immune therapies. Dr. Opyrchal will talk about this part of this slide, but I just want to show you how many more CAR T cell clinical trials for what type of cancers that we have now. So as you can see, the majority of them are made and developed right now for the treatment of B-cell lymphomas and B-cell ALL, and then the CLL. And CLL is one of the very earliest tumors to be targeted by CAR T cells. And Dr. Lee and myself, the other day, we were discussing a paper that showed or described 10 years follow-up on 2 patients treated 10 years ago at the University of Pennsylvania. And they both have CLL, and they still are considered cured basically after all of this time. Worldwide, again, the number of clinical trials for CAR T cell is increasing. China is doing most of this work. China is this bluish color here. They have almost 300 CAR T cell trials going on right now. There were about 70 in Europe and about 230 in the United States for this CAR T cell approach. Please remember that Multiple myeloma is considered sort of a B cell. Dr. Lee is an expert on that more than myself. But the B cell lymphoma, the ALL and the CLL are all B cell malignancies. They come, the original cell of that tumor is called a B cell. And then also there are a few trials that are targeting solid tumors such as gastrointestinal cancers. And here we need a lot more, and we need to face and navigate through many challenges to how to make this modality of treatment also effective and appropriate for solid tumors like they are for hematological malignancies or B cell tumors. Here at IU, we have a unique approach because most of the other centers, they are targeting B cell tumors. So here at IU, and our first clinical trial of our own CAR T cells will be targeting T cell cancers. And because of the uniqueness and that this patient population is in dire need for stronger therapy, our trial was amongst only 6 trials that was funded by the FDA a year ago to treat this type of cancers. So it is, we got a grant on this one, and we are redirecting CAR T cells to target CD4. CD4 is a protein that is located on T cells, and so this is for T cell malignancies. We have a program set in place right now, and we hope to develop this program into other types of cancers, including solid tumor, where we have a lot of need to make this particular treatment available to our patients. And Dr. Opyrchal is going to show you data on how effective this treatment is in solid tumors, as well as others, especially if whether it's standalone therapy or in combination with other treatments. And that is my part of the talk.
Dr. Opyrchal.
Well, thank you, Dr. Salman, for such a great introduction as we're working toward changing the slides.
Yes.
Now that everyone is an expert in immunology and CAR T cells, I'm going to focus our attention on some of the other aspects of the immune system, especially as it interacts with kind of solid tumors, and how we can use that to our advantage. So whenever we look at the immune microenvironment within the solid tumors, and Dr. Salman had an excellent slide showing multiple interactions, basically when we take out the immune system and immune cells out of that microenvironment, we look at the balance of immunosuppressive cells and immunostimulatory cells. And that balance ultimately results whether we have an immune response to the cancer or potentially kind of this immunosuppressive environment that does not allow our immune system to do much in interacting with cancers. So a lot of our approaches are really focusing on changing that balance. You know, whether we CAR T cell therapy, where we increase the killer T cells, and all of a sudden we change this balance, so we have much more of these cells going after tumor cells, or potentially getting rid of some of the immunosuppressive cells to allow that, once again, the balance to allow a response against tumor cells. So as Dr. Salman alluded, there are probably 4 main strategies to allow us to get immune response against tumors. And all of them can be viewed as targeting that balance and making the balance more positive to allow immune response.
I mean, can you switch over to presentation mode?
So when we think of immune therapies in solid tumors, I think a lot of people have heard of checkpoint inhibitors. And these are medications that really allow for T cells not to be turned off by cancer cells. So oftentimes what happens as T cell that's targeted against cancer cell finds cancer cell and recognizes it as foreign, there are other signaling pathways, whether it's CTLA4 or PD-1, PD-L1 interaction, that actually do not allow that T cell to kill the cancer cells. They're there for a reason. Most of them are good. It protects our GI tract, lungs, and things like that from overstimulation by our immune system. But in this case, obviously, it's not what we want. So checkpoint inhibitors are antibodies that interrupt this interaction and allow T cells to kill specific cancer cells. And certainly that has been an amazing therapy that's changed paradigm in treating a lot of the solid tumors. But as we continue learning about these interactions, we certainly know that it works only in certain percentage of patients. Some of these continue to progress despite this therapy. And then, unfortunately, most of the patients with solid tumors do not receive either minimal or no benefit from this therapy. So we need to continue to do better. Another strategy through vaccinations is, once again, targeting that balance by vaccinating patients. We try to increase the number of T cells that recognize tumors. So we're trying to change that balance and increase number of cells that are supposed to be recognizing cancer cells and attacking them. There are several strategies to do that. Certainly, borrowing from Dr. Coley's research, using viral vaccinations, whether there are non-specific viruses that infect tumor cells and cause generalized immune response that then improve infiltration of the T cells and recognition of the immune system for the cancer cells, or more specific viral vaccinations that either carry parts of the cancer proteins within them or carry some immunostimulatory proteins that allow even more robust immune response. But overall, they all target that balance, meaning increase the number of immune recognizing or tumor recognizing immune cells and increase the numbers to overcome immunorepressive parts of the immune system. Another type of vaccination is probably a more recognized, which is we take part of the tumor or protein from the tumor, and as standard viral and bacterial vaccines work, we inject it into patients in hopes to get a robust immune response and once again increase the recognition of the tumor cells and change that balance. Last one is a different type of vaccinations where we actually take out the cells that recognize, they're supposed to take out parts of the vaccine and then stimulate the T cells, which are these dendritic cells, as Dr. Salman showed you. So we take out these cells from patients' bodies. We kind of arm them against tumors, meaning we grow them in the lab in presence of tumor antigens that we know is going to be recognized by the T cells. We activate the cells, and then we inject them back into a human body in hopes they're going to find specific T cells, get them activated, and those T cells are going to recognize cancers and attack them appropriately. That was seminal work back in the 90s and 80s, which resulted in an approved agent against patients with metastatic prostate cancer. Overall, this wasn't very successful clinically, meaning there was some activity there and some patients lived longer. And I think there was certainly a population of patients that received great benefit from this, but overall, it didn't work very well. But I think where we wanted to highlight, this was one of the first immunotherapies approved in cancer. And I think gave us a hint that this can work in solid tumors. And I think looking back, this was one of the great kind of catalysts that not only can work, but also can be approved by the FDA, which stimulated a lot of work and push into clinical trials of these therapies. When we look at the world of immunotherapies in solid tumors, so certainly checkpoint inhibitors are still the main treatment. But as you can see, over the last 5 to 7 years, there's been an amazing increase in number of these medications that are approved in treatment of solid cancer. So it really has changed the paradigm of how we treat these cancers, whether in early stages, late stages, and everywhere in between. And now there's a push to really recognize better combination strategies. And then is there a way to replace some of the checkpoint inhibitors by other potentially better therapies so more patients can get benefit from immunotherapy. So why immunotherapy? I think, we just spent an inordinate amount of time, and you guys hear it on TV. So why immunotherapy? So whenever we look at treatment of solid tumors, we certainly know chemotherapy. So this is a aspect of patients with advanced cancers. So we give these patients chemotherapy, and some of them get some benefit, but eventually everyone starts progressing, and at the end, almost everybody progresses. Then there was the advent of targeted therapy. There was great excitement, and certainly they had much less side effects than chemotherapy, so that was great. And oftentimes they had much better activity if we find that perfect pair with a target and cancer. But it was the same problem that, although more patients receive benefits and they receive benefit for longer, eventually everyone continued to progress. And at the end, everyone progressed on these therapies. So then first checkpoint inhibitor came on. And as you can see, it wasn't necessarily much better than chemotherapy in how many patients responded. Certainly wasn't better than targeted therapy. But why it caught everyone's attention is right here. So there was a 10 to 20% of patients who responded and then continued to respond for a prolonged period of time. And as we improve our immunotherapies with second generation checkpoint inhibitors and then combination therapies, and obviously where we see the future is where immunotherapy not only gets better responses, but really gives us benefit for majority of patients with cancer. So I think this is a great example of what we're trying to achieve. So this is a great graph. Now a little bit of, it was presented in 2018, but what this is showing is patients that had metastatic melanoma. So 10 years ago, this was a horrible disease that most patients died within a year. So this is representation of patients that received immunotherapy for 2 years and then they stopped. And majority of these patients had no evidence, and this graph now continues for decades now, where after stopping therapy, they have no evidence of active disease. And I think, at which point do we call it cure or control of the disease? Ultimately, they continue to live their lives normally without any evidence of active disease. And I think this is where we get excited when we hear immunotherapy in treating patients with cancer. So going back to this graph, I wanted to highlight some of the things that Indiana University is working on projects that are very close to the clinic. So I wanted to highlight a couple of these projects. So 2 of these projects are targeting these immunosuppressive cells. So one is going to be targeting the MDSCs, myeloid-derived suppressor cells. One is going to be targeting regulatory T cells, in hopes to kind of change this balance again. So get rid of some of the immunosuppressive cells to allow a good part of the immune system to do its job and attack cancer. The other project is going to be trying to increase the number of these cells that recognize tumors, but they're just not doing enough to stop the tumor growth and stop it from progressing. So the hope is that we're going to be able to remove these cells from patients, increase their numbers in the lab, and put them back into patients. And once again, hopes that by increasing these numbers, we're going to be able to get them to a point that they're going to be able to overcome the immunosuppressive parts of the immune system and get us to a point that we can get rid of the tumor. And the last one is going to be targeting the NK cells, which are part of these cells that we haven't quite mentioned, but they're an important part of the immune system and their ability to work with all other parts of T cells and dendritic cells to allow immune recognition of cancers and killing them. So once again, we're going to try to take some of these NK cells, activate them outside of the patient's body, and put them back into patients to allow immune responses. But I think this graph highlights the complexity of the problem that we're facing. So certainly early successes have really got us all excited. As you guys have heard throughout all of this, is that for majority of patients, it's not going to be a simple one treatment that's going to get rid of tumor, but we're going to continue to learn from all of our trials and identify more and more of these points of interaction with the cancer and the immune system that allow cancers to avoid it and continue to grow. And as we learn that, we're going to be able to better identify patients that are going to either benefit from specific therapies or are going to be able to go on some of these clinical trials, which we believe is going to push us another step forward and get us to a point that most patients receive benefit from these therapies. Well, thank you for listening, and we look forward to answering some questions.
Great, thank you, Dr. Salman, Dr. Opyrchal, and please, if those of you who are listening or watching or both have questions, please type them in the chat, and we will pose them to our experts. As people are doing that, we actually have some questions already from our audience. And really, I think one of the more important questions is for both Dr. Salman and Dr. Opyrchal. I mean, this seems like it's brand new. I mean, 5 years ago, nobody was talking about immunotherapy. There were no ads on television. So I think it's important. Is this type of treatment mainstream for current cancer care, or is it still experimental?
As Dr. Opyrchal has shown, some of these agents are FDA approved. So that means they are, or some of them are in the mainstream. However, like with everything, we have lots of room to improve and make them better. And that's where the experimental part is still there. And that's where we're working on making either more of them or the existent ones are making them better, either as a standalone treatment or in combination with others. So it's both ways, Dr. Lee.
Yeah, I think, you know, we've all seen the explosion of number of agents and advertisement with it for treatment of cancer, and certainly has been changing therapy for solid tumors over the last 5 years, and there's great excitement of how we can make them better.
And how ultimately, how important do you think immunotherapy is going to be in, for example, the combination with other agents? How important do you think it's going to be for the treatment of cancer? Are most of our cancer patients going to have a immunotherapy piece in their treatment? Some of them, very few of them. What are your thoughts on that?
I would like to say, let's make it available to everybody by increasing the research on that. And the reason I say this is because we have proven that it's efficacious and that the positive effects of this treatment, they last longer than those of chemotherapy and or radiation therapy or even surgery. But not only because of that, but also because that they probably carry less side effects than chemotherapy. Chemotherapy kills the good and the bad, and it just is associated with lots and lots of side effects. Immunotherapy might have much less of those. And so if it is possible and we can create immune therapies for all sorts of cancers, then that will be a better approach than the chemotherapy, basically.
Yeah, and I think it's, I always see it as a side effect of our drug approval process, you know, that it's much easier to add new drug to standard of therapy, which really for decades has been the chemotherapy, rather than do a standalone trial of comparison. So the first really wave of approvals have really been the whole idea of adding another drug to the standard of therapy and showing that it works better. I think the next wave is really going to be starting to cut out parts of the treatment which we don't believe is stimulating the immune system, or certainly can suppress immune responses. But my belief is that majority of patients in the future are really going to be receiving immunotherapy for treatment of their cancer.
Great, and to follow up on that, I mean, so the patients that I treat are in multiple myeloma, and as you alluded to, There has been a brand new chimeric antigen receptor T-cell therapies in multiple myeloma, just approved by the FDA, I believe, last year. And when I was at my former institution, we were involved in some of the very early phase 1 clinical trials with these BCMA CAR T cells for multiple myeloma. And I have to say that these patients had really failed every standard therapy that was available for them for the treatment of multiple myeloma. Some of them had gotten 10 different kinds of chemotherapy over the course of 8 to 10 years. And really were coming in with the worst of the worst kind of myeloma, and a lot of it. I mean, I would say that many of our patients really had kilogram quantities of multiple myeloma, and then they got their CAR T cell infusion, just one infusion. They had an enormous immune response with some of the side effects, which I'll ask you guys about in a little bit. But within 2 weeks, many of our patients had complete eradication of their myeloma, at least in the short term. Unfortunately, many of them came back a year later, but it was, I have to say, in the 25 years that I've been treating myeloma patients, these were some of the most dramatic responses in getting rid of myeloma that I have ever seen. So I was wondering what your thoughts on why is immunotherapy different? I mean, why can't we do this with chemotherapy or radiation therapy? What's so special? I mean, it's almost like magic. I mean, why is immunotherapy different than the other kinds of therapies that we've been using for a very long time in cancers without these kind of dramatic effects?
I think part of the answer to your question is that the immune system is not playing with you if you do not stimulate it, because it is already hijacked by the cancer through the mechanisms that I showed in my war slide. And then you give chemotherapy, and then you could also put the immune system further down when you treat with chemotherapy, because chemotherapy can take the immune system down. However, it's that killer treatment. So like I said, it kills the good and the bad. The bad is the cancer, and the good is the immune system and other systems in the body. And so you lose that chunk of benefit that comes from the immune system naturally, which is our first defense. I always tell my students that we're sitting here developing DNA errors all the time, and that will result in cancers all the time. But there is this guardian in our body, which is the immune system, that is taking them down when they are very little before they get hijacked by the immune system. And I think that's part of why when we realize that if we augment that part and make it better, then we will get better results than if we use chemotherapy or whatever other modalities that were available to us in the past and still are.
Yeah, and when you really look at it, all therapies is immunotherapies, right? I mean, chemotherapy, we have learned over years, it really works, you know, the way it's described. Yes, it's supposed to kill cancer cells, but really for it to really work really well, it needs to stimulate parts of the immune system. So throughout all of our years, you know, we've seen these patients that had these remarkable responses to chemotherapy that were prolonged, and that's because we're able to get that balance perfectly. But because chemotherapy does not really target the immune system very specifically, it was far in between that we're able to strike that perfect balance. And as we now understand things better and better, like the Salman, you know, kind of getting the CAR T cells, which is that perfect target for the cancer cells. So getting this really immune responses against tumors is really going to get us. So yes, chemotherapy can get us there, but unfortunately, it's not specific enough to get us there in majority of people.
And I have a very good colleague and friend of mine who said that immunotherapy is a living drug. It's like getting vaccinated for COVID or anything else. I mean, you only get vaccinated once, but your immune system is there for the rest of your life. And it's fighting against what you got vaccinated for. So immunotherapy generates a living drug that continues on in your body long after you've done with treatment, which is what Dr. Opyrchal showed in that melanoma study, that you stop therapy and you still have your immune system fighting your cancer, or hopefully just eradicate it, but maybe just controlling it so it never shows up again for the rest of your life. So it's a very promising, there's a lot to learn about that. So let's go to the side effects. Okay, so I was talking to a patient and I said, well, we're gonna start you on immunotherapy and you won't lose your hair. And they said, well, that's good, but there's always a catch. So what are the other side effects that I should expect to see that may be unique to immunotherapy or different kinds of immunotherapy that, you don't really think about, that are different than what one sees with radiation therapy or chemotherapy?
Okay, so I am going to touch on the side effects of CAR T cells, and it's the part of immunotherapy that we just refer to as living cells, basically, or living treatment. And I will leave the checkpoint inhibitor side effects and all the other ones to Dr. Opyrchal. So for the CAR T cells, these cells we give them, let's suppose that I give a patient 1 million cells. It's a good number, but it's not enough. They need to expand inside the human body. And for that, they have to have fuels for them to expand. And those fuels are what we call cytokines. So once you put them in there, and to maintain themselves and to go multiply and proliferate, they will also secrete certain proteins to keep them going. These proteins are called cytokines. Now, these cytokines are in an excessive amount, like the one that is produced with CAR T cells, is responsible for the majority of the side effects of CAR T cells. Because it indicates that the body is in an accelerated status of producing these cells, and these cytokines they cause certain changes in the human body. One of them is that it causes water retention, it causes leak across membranes such as the blood-brain barrier or membranes around the lung or in the liver. So it causes fluid accumulation, and that's where their toxicity is coming from. They produce fever, they produce all these sort of side effects. But the good news is we can control this in almost every patient, or the vast majority of them. And we can control them by anti-inflammatory medications such as steroids. And I always like to tell the story quickly of the very first patient who was treated with CAR T cells at the University of Pennsylvania, where they did not realize that this is coming, this cytokine storm that is coming. And then the PI on that, or the person who was treating these patients, Dr. Carl June, saw that, and in the middle of the night, they called him, oh, we have this patient who is about to die because of all of these side effects secondary to those cytokines. So he thought about it for a second, and he remembered that he knows somebody that has rheumatoid arthritis, which is an excessive activation of the immune system at its basis, and that these people are getting treatment with a drug that will take the immune system down. So he decided to give that patient that drug. It's called tocilizumab, and all of a sudden everything was gone under control again. So now we know how to treat them. We know how to suppress these cytokines when we need to, but it's a balance between keeping some of them going so the proliferation and expansion of these cells continues while the patient does not have lots of side effects.
Yeah, and obviously, immune system is a very, very powerful tool. And cancers have not invented ways to suppress our immune system. These are all pathways that our body uses to control immune system. So if we let our immune system go and not be controlled, certainly we wouldn't be alive. So as we tweak this balance within the tumor of immunosuppressive and immunopermissive parts of the immune system, we want to be careful we don't change those balances in places that we want that balance to be immunosuppressive. So certainly side effects can be many, and we worry about it. We have gotten much better about recognizing them early. So I think recognizing these side effects early is the key to controlling them and not allowing them to get out of hand and become life-threatening. But as I look at the side effects, our immune system is everywhere in our bodies. Therefore, any side effects is possible, but probably some of the GI side effects are more common. Some of the lung side effects, just because it interacts with the outside world a little more. But really, any side effects can happen.
Great. I think we have time for one more question, and we'll go to the question that has the social dimension. So these sound to be incredibly complicated, expensive therapies. And one concern is patients that have problems accessing the healthcare system, patients that may come from disadvantaged communities. Will they be able to get these therapies? And what are the challenges that you see that might not equitably distribute these kinds of life-saving therapies to our more disadvantaged patient populations?
So this is a great question, Dr. Lee. And so far, this treatment with all of its types and subtypes is extremely expensive. So we can say that only patients with insurance and a good insurance might be able to afford such treatment. Part of the reasons, and there are many reasons, is that they are produced by pharmaceuticals, which is the case for most of the drugs. Like I mentioned earlier to you, maybe when I was doing my clinical trial, my first 2 patients were uninsured and African Americans, but that was on trials. So, and the trial is funded by the FDA, so they could get the treatment. But once the treatment is approved and patients have to pay for it, then it becomes an issue. I think that one of the solutions for this is to continue to fight in the United States to take drug prices down. As I showed you in the number of CAR T cells, China had this very big list because it's cheaper there, because it's accessible. Here, everything comes with a very high price. So part of it is to take that fight into the community and try to make drugs less expensive. And I think that also the other part is to be able to manufacture these medications or living in academic institutions rather than only at pharmaceutical companies, because we get funded from the federal companies and we don't really look for much profit in academic institutions. And the more we do this, like I'm doing with my trial at academic institutions, if we could do that, then I think not only that we produce another drug that is it's going to compete with pharmaceutical medications, but also we have it at a lower price to start with. And then when we have it, they will have to drop their prices. So there are many things that we can do and educate the community and go to the government, go to the governor and tell them that, this is a very efficacious medication. We have to make it available to everybody.
Great.
Yeah, great highlighting the issues with the American healthcare system. But I think, really showing the importance of clinical trials. One, because these treatments that are widely available, some of them are great, but for most patients, it still doesn't work. And I truly believe, I always, the way I look at it, if I had cancer, incurable cancer, I would want to be part of a clinical trial because I truly believe not only does it help, future generations, but really that's our best chance of, getting a disease control for our patients right now. So certainly as part of the clinical trials, we're trying to improve our outreach and really the communication with how we talk to the patients to make sure they understand that clinical trial doesn't necessarily mean guinea pig and kind of overcome some of those fears of a healthcare system. But really clinical trials, we really are looking at new therapies which we believe are going to become standard of care in the forthcoming years, but now we have access to them earlier. We probably we can always do better, but we continue learning it, and we're working with our outreach programs to do better, get a better message, and really be able to talk with people on their level.
Great, thank you. And I'll just close the session by saying I want to second the participation in clinical trials. Way back when I was a medical student, which was before they invented electricity, I think, the time that took from a new therapy to go from clinical trial to being FDA approved was, oh gosh, probably 10, 15 years. I mean, and it was almost never that something, that was discovered in the lab would end up in patients, helping them with their cancer, before half a decade or a decade. Now, I would say, for example, that BCMA CAR T-cell trial that I talked about, it was a matter of 2 years between the time that it started off in phase 1 studies, phase 1 clinical trials, till it was FDA approved. And in fact, I believe the one version of the BCMA CAR T-cell trials was approved off of a phase 1, phase 2 clinical trial. So the speed by which life-saving therapies, including immunotherapies, are ending up in actually being part of the armamentarium to treat or cure cancer is remarkable these days. And so I think that is another reason it's to be involved early in the clinical research, especially in the context of immunotherapy. So with that, I think I'm getting the checkered flag to stop talking. So I will turn it over to Jose to show us what we have upcoming for the next Simon Says. But I also want to thank Dr. Salman and Dr. Opyrchal for their wonderful insights and teaching us all sorts of new things about immunotherapy, and really thank our amazing production and communications team, and then thank all of you who are listening and watching for participating. If you have any questions, please let us know, and we will try to get you answers. And with that, I think